So welcome, everyone. Thank you for joining us this afternoon at our session focused on health equity. My name is Caroline Quijada, and I am a SID-US board member. And along with my co-designer for this session, Bobby Jefferson, we have put together what we hope is a very exciting and thought-provoking panel for you this afternoon. I want to start by introducing the panelists. We are expecting one additional panelist, and that's Nidhi Bori, the Deputy Assistant Administrator from USAID. She is on her way, so we will make room for her at the table until she arrives. But I do want to introduce my co-pilot here, Bobby Jefferson, who is also on the SID-US board. Bobby chairs the DEIA subcommittee and is also a member of the executive committee at SID-US. To Bobby's left is Dr. Hedayatullah Saleh from APT Global, who is a senior health specialist. Initially trained as a physician in Afghanistan, Dr. Saleh is a public health expert and an international development professional with over 22 years of expertise in the private and public development sectors. He has a proven record of successfully leading and executing service delivery, capacity development, and organizational sustainability programs. His core areas of expertise include maternal and child health, private sector engagement, health system strengthening, and strategic and operational planning and management. He has held several senior roles supporting the health system's strengthening efforts in Afghanistan. And he and his spouse and their children are currently residing in Alexandria, Virginia. So welcome, Dr. Saleh. To the left of Dr. Saleh is Dr. Wilfred Cadet, who is the Chief Medical Advisor at Health Equity International in Haiti. Dr. Cadet is a licensed pediatrician trained in Haiti at the State University Hospital. He graduated from medical school in 1994 and first joined the St. Boniface Hospital as a social service physician, eventually rising to the position of hospital director. Under Dr. Cadet's leadership, St. Boniface Health Center became St. Boniface Hospital, which was fully accredited and licensed by Haiti's Ministry of Health. Dr. Cadet holds an MPH from Boston University School of Public Health and has worked with a number of development organizations in the field. He is an environmentalist and a women's rights advocate and has long been involved in children's empowerment through education, sports, and arts. And then to his left is Andrew Chambade from RTI International. Andrew is a results-oriented development specialist with over 25 years of experience planning, designing, implementing, managing, monitoring, evaluating complex health programs in both the public and private sector. The majority of his time, his last 22 years, in fact, was spent with USAID Uganda, where he managed global and country health system strengthening programs. He worked closely with the host government. He has technical experience in implementing all of WHO's health system building blocks. Currently, Mr. Chambade leads USAID's Act to End Neglected Tropical Diseases East program to implement sustainability plans for neglected tropical diseases, provides targeted technical support based on country needs, and is working to strengthen ownership and leadership of those programs. So welcome, Andrew, to the panel. And then last but certainly not least, welcome Nidhi Bori, who was appointed as Deputy Assistant Administrator for Global Health at USAID in June of 2023. She previously served in the Biden-Harris White House, most recently as the Senior Advisor for Foreign Policy in the Office of the First Lady. She has served on the National Security Council, first as the Director for Global Health Response, and then as Acting Senior Director for Development, Global Health, and Humanitarian Response. Ms. Bori is a global development and foreign policy expert with 17 years of field-based experience, focused on building partnerships, driving strategy, and leading dynamic teams in complex environments. She previously served in USAID's Bureau for Humanitarian Assistance, as well as was the Deputy Executive Director and Chief of Staff for USAID's first COVID-19 task force. Nidhi holds an MPH from Johns Hopkins Bloomberg School of Public Health. And we are very, very happy to have Nidhi here with us today.
Great. So please, we'll let you start first.
So we are going to have Nidhi give us a few opening remarks on health equity. Thank you, Nidhi.
Thank you.
Thank you so much. And I apologize that I was a couple minutes late in joining the panel, but thank you to the Society for International Development for giving USAID an opportunity to participate in this panel. As many of you hopefully know, equity is really central to the work that USAID does across all sectors, of course, including health. And so I'm really grateful to this panel for providing a forum to specifically highlight ways and exchange ideas of how we can particularly advance equity in the global health space. It's critical that we, as a global health community, make sure that when we talk about a vision for health equity, we also talk about how we will actually achieve that vision. In 2022, USAID released our first equity action plan. And then earlier this year, we released our second equity action plan, which focused on reducing barriers for USAID partners, enhancing accountability measures and non-discrimination protections for program participants, employees, and contract staff, and of course, advancing equity across all of our global work. Addressing health inequities has become even more important and challenging for us in a post-COVID-19 era, where we saw how great the exacerbation of inequities were across the world as a result of increased socioeconomic and health barriers affecting all communities. Marginalized and vulnerable populations, of course, bear the burden. And compounding crises like the climate, like conflict and climate crisis are making it even harder to address the challenges that these groups have faced. Advancing health equity is not just about ensuring that affordable and quality health services are accessible to all people. It also means continuing to reform the global health architecture and reevaluate how we actually implement health programs so that we do our part to reset power dynamics, ensure the meaningful inclusion of local partners, and fundamentally ask hard but needed questions to ensure that the systems and processes that we all work with are actually designed and centered to support communities everywhere. At USAID, health equity is the foundation of all of our work and in the way that we also approach our programming. While we aim to advance equity across all our programs, a major component of this is specifically in our work to advance health system strengthening, which integrates the principles that promote improved healthcare access and quality for all populations, including marginalized and underserved populations, to ultimately ensure that health systems are designed for and by all people. As described in our vision for health system strengthening, health equity is fundamentally based on the principle that all people should have a fair opportunity to achieve their health potential. Healthcare is equitable only when people who need it are able to actually access it in trusted ways that are available to all, including those who are marginalized, underserved, and vulnerable. Advancing health equity is also central to our ability to achieve the United Nations Sustainable Development Goals, which are founded on the promise to leave no person behind. Many of the individual Sustainable Development Goals collectively rely on building health equity, many of which are core USAID priorities, such as advancing primary health care and accelerating progress on universal health coverage. And this is what poses the fundamental question for us at USAID, which is how that we at USAID can actually operationalize our health equity efforts. First, we are increasing efforts to center relevant aspects of identity, including gender, disability, and other demographic factors within the context and within the aim to increase social inclusion across all our programs. Through the incorporation of context-specific marginalized and vulnerable groups, we center health equity in a programming design process, monitoring evaluation, and ultimately in oversight. Second, we are leveraging our health systems investments including our community health systems work, to empower disadvantaged groups to influence programs and policies intended for their benefit. For example, in Guinea, USAID recently supported implementation research to specifically understand how new national policies for community health that targeted rural and underserved subdistricts was actually being applied, and essentially what the actual interface was with communities it was intended to serve. The goal of that research was to give us quantifiable data in what we needed to do to actually improve health equity, both in terms of how to document health outcomes, but also in how we could have increased accountability in how we do that work. That's just one example of how implementation research or other areas of work can help bridge the divide between the academic tenets of health equity and the actual real-world impacts on communities. USAID also recognizes the critical role that the social determinants of health have on health outcomes across all of our programming priorities. We understand the need to address fundamentally the root causes of inequities and their impact on healthcare access, quality, and other aspects of the ability of individuals to actually access services and ultimately for systems to be more resilient. All of this is key and central if we actually are serious about achieving universal health coverage. An active recognition of social determinants of health enables decision makers, as well as those supporting different public health investments, to actually guide and change policies and strategies in a way that is enabling and not limiting. USAID is also looking more closely internally at equity just within our own programs. In our bureau, in the Global Health Bureau, we are in the final stages of conducting a disability inclusion assessment to provide recommendations for meaningful engagement of persons with disabilities in our program design, implementation, and monitoring and evaluation and learning processes. And this is a similar effort to what some of our sister bureaus across USAID are also doing. Additionally, we're looking at more concrete ways to measure equity outcomes through metrics and data. By exploring whether USAID can use data from WHO's Health Inequality Data Repository, we hope to monitor progress on health equity across our priority health areas. And another key source of data for us are the USAID-funded demographic and health surveys, which make meaningful data that can be used for context-specific analyses of inequalities. This work is being accelerated by our fundamental focus on primary health care, which takes a comprehensive approach to health that combines multi-sectoral policy and action, community empowerment, and a significant amount of collaboration and communication among health professionals. It employs a person-centered approach where we can be proactive in care, health promotion, disease prevention, diagnosis, and treatment, and ensuring that all of those services are delivered equitably by multidisciplinary teams as close as possible to people's everyday environments, reducing morbidity and mortality across the lifespan. To that end, in 2022, we launched Primary Impact, which is an effort to ensure that USAID's investments collectively strengthen primary health care, particularly working through our colleagues at USAID Missions, who are closest to the communities that we work in partnership with. Key to this initiative and many of our other efforts in global health is a fundamental focus on health workforce. Health workers are the backbone of health systems, as many of you know, across the globe, and they are key to achieving health equity for all by reaching underserved populations and the most vulnerable groups and communities. Health workers, and in particularly community health workers, are also experiencing their own inequalities, as we know that 70% of community health workers are women who are drastically underpaid. The ability to reach groups excluded from the health system and improve health outcomes for the most marginalized is something that health workers are really the only avenue to help us do. Investments in health workforce, therefore, we see as a very tangible way to actually concretely advance health equity outcomes. We are working to address challenges, as I mentioned, such as inequitable payment, and improve safeguards, protections, and other issues through and in support of the administration's Global Health Workforce Initiative. And for the first time, USAID has received an earmarked appropriation to support global health workforce under this initiative. In these ways and many others, USAID is taking an active role in centering health equity at the forefront of all of our development work, recognizing that underserved and marginalized groups in each community and the social determinants of health that impact their health outcomes is critical to ensuring that the work that USAID supports across the globe is impactful, mission-driven, and most importantly, centered in communities and their agenda and vision for what they want to achieve. Thank you again for having me today, and I look forward to discussing with our panel.
Wow, thank you very much for that. We appreciate your presence and being here. You walked a long way to this conference room. Please, I'll take a minute. Please sit down. This is a shared space. This is a safe space. It's a long, Rob, how are you doing? Just want to relax. We know each other. We're a part of the global health family. The conference title is around sparks of hope, especially in crisis. So you're going to hear from 3 experts who've lived this in 3 countries. So Haiti, Uganda, Afghanistan. And even though each of the speakers are representing their organization, they represent themselves in their voice as well. So just putting that caveat out there so that way we're able to have really robust conversation. So I'm going to start with Dr. Saleh. You're from, let us know where you're from, which country, and because Afghanistan has suffered from conflict for at least 4 decades. And so when it comes to health, global health inequities, what's been your experience? And what lessons can you share about that, being on the ground there in Afghanistan?
Is this on?
Yeah.
Thank you, Bobby. Thank you very much. In 2002, right after 9/11 and the subsequent events that led to the creation of a new political system in Afghanistan, what we are referring to as the post-Taliban 1.0 era. The country faced enormous gaps from a health equity perspective. Less than 15% of the population had some type of access to essential health services, which hardly met the criteria of universal health care in terms of scale, quality, and distribution, even for that 15% that I mentioned earlier. A key equity issue was poor access to essential health services by the most vulnerable. Those were people living in hard-to-reach rural areas, women, and children. With support from bilateral and multilateral donors, international organizations, and the academia, the Ministry of Health at that time laid the foundation of a new health system. It did so by taking a few bold steps, and I want to mention some of those bold steps that the ministry took. First and foremost, a new health system, a health service delivery system was put in place. A basic package of health services was developed for which tiers or layers of service delivery points, or what we call the health facilities, their catchment areas, their resource requirements in terms of staffing, equipment, and medicine were defined. That was the first. As a second step, rural underserved areas were put on top of the list in terms of the priorities. Third, given limited capacity of the Ministry of Health at that time, a third-party based model of service delivery, or what we call as a contract out modality for service delivery, was introduced. Initially, those service providers to which the the services were outsourced were international NGOs, and over time, local NGOs became capacitated, and then they took over.
So are you saying that the local NGOs had the capacity to manage and run the clinical services?
Not initially. Initially, it was the international NGOs, and then over time, national NGOs were basically born, capacitated,
Excellent.
and then they took over.
Okay.
The fourth one was adoption of a community-based healthcare model, where communities became actively involved in their own health by committing resources, including manpower, that they could be deployed as community health workers and community midwives.
How did you get the community buy-in? Because that's always a challenge.
Yes, it was a challenge, but I think the close engagement with the community was the key. And basically, it was also in a way new for that community, because as I said, the hard to reach areas had been neglected. So the fact that development partners and the government would come and talk directly to the community and basically say, see, these are the resources we are committing, but it's not going to work. It's not going to be sustainable if you do not participate. If your sons or daughters do not get trained and deployed as midwives or health workers, and that's how they participated and allocated resources. And then the last one that I wanted to mention was that the Ministry of Health made a strategic decision to basically just play the stewardship role by developing and enforcing policy strategies and norms, and also focusing on building the capacity of those local NGOs that I said that were just initiating or emerging, and trying to help them flourish.
Thank you for that. So we're going to continue on that theme, because I've heard around rural and the difficulty of access. So I'm going to turn to Dr. Wilfred from Haiti, and I'm going to just ask a little bit about, there are many challenges in Haiti around rural access, mountainous regions, lack of roads. That's it. What was your approach and your experience to help achieving health equity within that context? And which part of Haiti did you work as well?
So I come from the northern part of Haiti, northern part of Port-au-Prince, but as a must for any new medical graduate, you have to spend 1 year what we call in Haiti social service. So I ended up working in the south of Haiti, which was very new to me. So when I got there, I want to share an anecdote with you regarding health inequity. So young doctor, so mostly very poor rural community. But after work hours, I would receive invitations and calls from some members of the community to be seen in their private homes. So those are people, like I would say less than 1% of that community, who had enough money, who asked the doctor to come see their family member at home. So because they don't want to wait at the clinic. So
Patient waiting times. Yes.
yes,
Yeah.
we all know about that. So I mean, this talking about health equity in a place where 99% of the population do not have access to social services. So basically you're working in a context where the inequity is almost the norm, and you have to kind of revert it. So the message of hope in the midst of all this right now, in the midst of this crisis, we have two good partners. I mentioned USAID Haiti Health Office and Kellogg Foundation, who have come forward and to support us in our mission, not only to serve the communities where our hospital is, but also to work with other health facilities in the southern region to build what we call health system strengthening, to allow those rural populations to have access to medical care, not only at the facilities, but more importantly, because we're talking about crisis and gangs activities. So it has become the must to work with community members to serve the other community members when it comes to primary care, prevention, education, et cetera, et cetera. Now, how did we get to this point? I mean, Dewey mentioned about social disparities. And the social disparities that we have in Haiti right now are the result of what the scholars call structural violence, which is basically the result of colonialism and decades of dictatorship and coup. So you have a mix of colonialism, occupation, and then in the midst of all that, dictatorship. Haiti has almost always ruled by dictators. And when you have dictators, you have centralization of power, centralization of resources. And where those resources are localized, it's in the capital city. So there has never been an interest to serve the rural communities. So that's how, when I went to work there as a young doctor, most people didn't have access to healthcare. And when you have this situation where there is drama in Port-au-Prince, basically there is no movement of goods and supplies, fuel, medicines to the other parts of the country, which makes it really challenging to continue to serve those who've never been served.
So how did you do that? Because I've been to Haiti, and some of the challenges have been, especially the community level, is trust. And because you're going to do an intervention, you're going to do a service, but you may leave in 1 year, 2 year when the grant is over. So as Health Equity International, in your experience, how did you go about as a young physician developing that trust within the community?
I would say, in my case, it was easy. And I will tell you why specifically, how I was able to establish trust with the community members. So when I was always kind of fascinated by the traditional birth attendants. And I have a certain, I would say, professional weakness for reducing maternal mortality. So in Haiti, for very long, 65% of deliveries were done by the TBAs. So I wanted to learn about how they're able to do it. I mean, we in physicians in our delivery room, we have all those tools, the drugs, the gloves, and then, so how did they do it? So when I first went there, that was my first point of interest. Not to work with them, but to meet them. So I went to the book where I have all the names, where they are from, and I went and visited every single one of them. Why the TBAs? For that particular professional interest in terms of maternal mortality reduction. But at the same time, they have the knowledge. They have the respect from the other community members. They may not have a political voice when it comes to big decisions with the community, but in terms of respect and acceptance, if people see that, Mrs. X, Y, and Z, gets along well with you, definitely they will listen.
Then they'll listen.
Yes, even you young, like very like child face, they'll be like, oh, okay. Since the matrons, as we call them back home, they really took me in. Really total acceptance to work with that young doctor. And that's how I was able to establish that really trust with the community, starting with the TBAs.
Excellent. So it seems a common theme, both with you, Dr. Saleh, as well, is that establishing that trust within the community, that commitment. So Andrew, can you tell me a little bit about Uganda? Are there any conflict places in Uganda? I don't even know. Where in Uganda? What kind of work? Can you just share a little bit, just to set the context?
Okay, thank you very much. For those of you who don't know where Uganda is, it's along the equator. If you look at the African map, that's where the equator cuts across the continent. So Uganda is one of the countries in there, and it's well known as a Pearl of Africa. I'm going to talk about the Karamojong, who are a nomadic all-pastor community in Uganda. They are in northern eastern part of the country, and they're bordering Sudan and Kenya on the other side. So there is a pastor community, and because of the colonial borders, all three countries share the same pastor community.
Which three countries?
Kenya, South Sudan, and Uganda.
Great.
So ideally, the Karamojong are a pastor community. and all able-bodied men and boys are expected to be out in the field looking for scarce grass and water. That implies they are away from their homesteads for long periods of time. The Karamojong population is approximately 1.2 million. 50% of the population are women. And for the women, on average, they have 8 kids over their lifetime. This is way high compared to the national average of 5, because that has recently come down because of several family planning efforts. So the other issue is 11 million people in Uganda right now are free from trachoma. However, we do have 600,000 people that we are yet to reach, and a big part of that population is within the Karamoja reach. And we are having programs that need to focus on issues to do with health disparity to reach them. So knowing there's a community, men are not at home, big high trachoma prevalence in the setting, it's a big one. And for those of you who if there's anything you need to remember about NTDs, is that apart from being a neglected tropical disease, the way it's named, neglected tropical disease, it also affects neglected populations. So you realize there's a lot of issues to do with health disparities as far as NTDs are concerned. So that's a key focus.
Same question for you. How did you gain the trust of the pastoral community to be able to address the issues around NTDs?
And that's where I'm taking you. 2 issues: being intentional in prioritizing the target audience, and then 2, using behavior change agents to reach the communities. I'm going to give an example of each. For the target audience, there is a ripple effects mapping tool that was used. Wherever an activity has been done, for specifically this activity was following the mass drug administration for trachoma. They did a ripple map effects tracking and realized that men were missing from the recipients of the program. So essentially, they used that tool to identify men as missing, worked with village health teams, and the village health teams constituted only men because of trust issues. When the Karamojong are out in the field looking after their cattle, they don't want anybody they don't trust. And like I didn't tell you, every homestead in Karamoja owns an illegal gun. That's a known secret. The government knows. So that implies the issue of suspicion is extremely high. So having men constitute the village health team was extremely important to reach out to the men out in the field where they're looking after their cows. The other issue for the target audience in the homestead, it was very critical that it was realized that wash was a critical element. If you don't have a clean wash program, there's a high probability of transmitting trachoma. So if you have to do anything in a homestead where men are out, you have to deal with the women. So the behavior change.
And which one's the boss?
The woman is in the boss in the absence of the man. Okay. So in this instance, the behavior change agents who were household models, only women, were used to influence women to be able to improve the hygiene and facial cleaning in the household. So those were the 2 spark principles that were extremely critical to break these barriers in the Karamoja region.
Excellent. I've got a number of follow-up questions, but before I get to them, I want to ask Nidhi, you know, a lot of the work that USAID has been doing requires multi-sectorial approaches, especially in the global health. Which parts of other parts of the agency and USAID, you know, do you collaborate and work? Because I was very heartened to hear around disabilities and working with people, because in conflict zones, whether that's Ukraine, Afghanistan, Haiti, there are many people with disabilities as well because of the conflict. So which, you know, within USAID itself?
Sure, thank you. So some of you may be familiar, USAID is organized by both regional focus bureaus as well as what we call functional. So global health is one of those. We have pretty strong partnerships really across all bureaus. They just are utilized in different ways. So particularly with other functional bureaus, we've seen tremendous opportunity to work on how investments in health can accelerate gender equity and equality goals, how we can pair efforts on education. One recent example is USAID, and also talking about health equity. USAID's our administrator has issued a call to action to address lead poisoning, which is 100% preventable, and yet disproportionately impacts primarily young children in lower middle income countries and has huge setbacks to their neurological and educational development progress. And it's an example of how actually the agency has come together, our colleagues in the Health Bureau, colleagues who focus on education, who were focused on economic development, on gender issues, to really look at problem sets and barriers that pose challenges and look at essentially what we can do to overcome those. We also have an increased focus in coordinating our efforts with our colleagues who focus on food security and agriculture. So whether that's in nutrition, of course, we're seeing the worst global food security crisis in our lifetime. But we also have seen a lot of opportunities to think forward, for example, as we look at efforts in the global health security space, where when we look at zoonotic spillover from animals to humans, many times the mitigation effort is culling animals, but that's a livelihood for someone, right? And so if we can actually look at where our programs align that support agriculture and livestock interventions that are resulted or linked rather to livelihoods programs with our health programs, we can make sure that our holistic efforts for USAID are really just designed in supporting an individual, right? Individuals at a community level and all the things that impact them.
Thank you for that. Let me ask a sensitive question to my colleagues. Currently, Afghanistan is under Taliban rule and has been there. So what programs of success or, the type of work that can be done that you've seen that actually has worked under the Taliban rule?
Sure. Immediately after August 2021, when the former government collapsed, and in other words, when the Taliban took over Afghanistan, access to health services or to that basic package of health services that I mentioned earlier faced a significant threat. The entire health system, in fact, went into shambles. And donor assistance, which almost entirely funded the delivery of that basic package, was cut. That's because the engagement with the international community was disrupted. As a result, millions of Afghans who had already become quite vulnerable due to protracted armed conflict for decades, the COVID pandemic, as well as very prolonged drought and food insecurity, they faced a new challenge now, and that was losing access to life-saving health services. Fortunately, an emerging disaster was prevented relatively quickly. The donor community restored contact, and they regrouped to find an alternative funding channels. Given the new operating context, they had to bypass the new administration, which is still being heavily sanctioned by the international community. The donors were successfully able to, unfortunately, agree on a pooled funding modality through the United Nations, again, as I said, bypassing the new administration. And I believe what truly helped avert the disaster in making were the following. First and foremost, the fact that donors were quickly able to agree on a plan B. Second, the existence of a package of services and that contracting out modality particularly through non-governmental actors, because here, the new administration or the new so-called government was the main point of contention. And finally, the fact that the new administration, didn't block the alternative funding mechanisms. They allowed it to take over. Those were, in a way, the life-saving for, for millions of people, which helped, continue the delivery of those essential health services.
Great, thank you for that. So just to let you know, I'm going to open up to the audience in another 2 minutes for 2 quick questions, and then we'll bring it back to the panel. So start thinking about your compelling question to ask the panel. And then I'm going to ask both Dr. Wilfred and Andrew the questions together. So for Andrew, can you just tell me more about how did you go about ending, addressing the neglected tropical diseases for underserved and those communities? Because how do you navigate that when there is a challenge in the governance side of things? And for Dr. Wilfred, similar, like how do you go about navigating and doing the work when the central government itself is in crisis of the constant change? Because this is the reality that we live with, and we're trying to do health system strengthening in countries that have very weak, you're not building a ministry of health that has capacity or people or those sorts of things. So if you can address those those questions, and I'll turn it over to the audience for Q&A.
Okay, for the case of Karamoja, it's a very delicate and complicated setting. First of all, there is a lot of mistrust between the Karamojong and government, and that has a history. In 1979, when Idi Amin was being overthrown, the Karamojong invaded the barracks in their setting and literally got tens of thousands of guns out. So, and they own the guns now. Subsequent governments have come out and tried as much as possible to mine the guns out of the community, with the little success, because they eventually cross over to Sudan and buy the guns and replenish the supply. So most of the activities that government has extended to this community in good faith, activities that are supposed to break health barriers so that they access services, the Karamojong are very reluctant to take them on because they think it's a suspicion to eliminate them. So that's a big one. The only way you can get into this community and allow, the men are out, but they're indirectly managing the households. They're instructing their ladies and kids, don't go for that service. The only way you can break that barrier is to get folks from within their community, get them to be part of the VHTs, get them to be part of the change agents, so that these are people who are respected in their community. Once they took on some of these services, they have the capacity to go and convince their own folk that, you know what, this is in our own interest. Let's take on such services. If you think you'll get into this community with your own definition of equity, you are in a big problem. You have to get in there, get to know what they perceive to be an equity barrier is, and then figure out how you use their own people to be able to get into their space, build trust, and break that cycle of
excellent point around what they perceive, the community perceives as the inequity and the barrier versus what we in the West perceive as the inequity. Dr.
I mean, for us, I think let me address exactly what has been impacted by the current situation. As one of the key building blocks is really to strengthen leadership and governance within the Ministry of Health. So without any government, it's really hard to really, reinforce leadership and governance, because, I mean, at the higher level, and everything is centralized, so that's difficult. But when it comes to the other element components, things are going almost as usual, I should say. But we're also doing what the scholar has called the socialization of scarcity. The very little resources that we have, we stretch those resources to the extreme to make sure we address the needs of the most vulnerable. But talking about the most vulnerable, I'm happy that you mentioned the people with disabilities, because from the 2010 earthquake, we have a big pool of people with disabilities in the country, and within our hospital, we have a spinal cord injury unit to really help those people. So, and one category of the population is the elderly.
Elderly.
Yeah, I mean, most programs focus on maternal and child health, which is absolutely normal. I'm not challenging that at all, but we tend to forget the elderly and
my age group. Yes.
Yes. So basically, we've been what we have been able to do is really to use the resources that we have from USAID, KLOG, and other great donors really to address everyone. Because as I said, yes, there are inequities, but it's almost, we're talking about 90% of the population, women and men, elderly and young, et cetera, et cetera, et cetera. People, those who have the resources, essentially, they mostly live in Port-au-Prince, and those are the people who can easily order an helicopter to come to Miami for medical care. They are not the focus of our interventions.
Okay, so just to have my facilitator role, I just will open it up for just one question, unfortunately. And then please, panelists, be able to share one takeaway that each of the individuals and organizations should be able to take away and use. So while you're thinking, so one question, please. Yeah, you had your hand first, and a microphone is here.
Thank you very much for giving me the chance. I'm Nkem Chukweme. I'm a public health physician as well. I've been doing public health for like 20 years. So I was just listening and tying up everything together. We talked about neglected tropical diseases, we talked about access, and we talked about health in fragile settings. And the beauty about it is that people at the lower level, at the grassroots level, their primary problem is different from the programs that we bring to them, which brings in the social determinants of health. So it comes back to integrated health service. Now, we know that USAID is doing a lot of efforts in terms of ISD. But at the same time, sometimes we wonder, is there some integration of teams at USAID? Is there integration of financing? Is there integration of tools? Is there integration of techniques? Such that we have a pool funding. And when we at the lower level, we want to run implementation, we have the opportunity to implement in that way. Why am I asking these questions?
Yeah, why?
In most of the NOFO, most of the RFA, most of the RFI, when you write a proposal, you're always told, get a co-financing or co-funding from another organization or from the government.
Yes.
To support an aspect that doesn't cover that particular program area.
Great.
So the question now comes to, is USAID really helping us to integrate those financing before it scales down? Such that when we want to provide a service for HIV or for TB or for malaria, we can also provide service for shelter, for unemployment, for jobs, just things that's it's just holistic for the whole person, and that's the real patient-facing, patient-centeredness. Thank you very much.
Thank you. Well, that unfortunately is a too long of an answer from the panelists. So I'm happy to afterwards really to have one-on-one conversations. So we'll be, because these are folks who are lived experience in the field with those verticals as well. But I do want to leave with the opportunity for Andrew, starting with Andrew, to leave you with one takeaway that you as an individual or as an organization can do. So Andrew.
Okay. Health disparities should be twofold. One, get to understand what the community perceives as an equity barrier. Once you understand that, build the solution around their own understanding. That way it's more sustainable and they will own the process when you're out of the place.
Here. Dr. Wilfred.
I'm going to get back to the community theme, and I will say strengthen community organizations. And I have another, I would say, experience about integration at the grassroots level. And we have those vertical programs starting like a community surveillance for malaria, one community group for maternal mortality, one for HIV, one for TB, but there are already existing groups in the communities that we just need to capacitate for them to address not only the health needs, but the social needs that they may have, whatever that social need is.
Here. All right. Dr. Sala?
Thank you, Bobby. We had time constraints. I was going to very briefly mention an emerging health equity issue in Afghanistan, and that is the health needs of the urban poor. While we, successfully in Afghanistan made gains in terms of meeting the needs of the rural, a new challenge emerged, which was, displacements to cities, and then, a huge vacuum of health services. The private sector is the largest provider in the urban areas of health services. And it's very important to proactively engage the private sector because the private sector also grows exponentially. So delaying engagement in the private sector is going to be a lost opportunity, and averting all those losses is going to be quite costly for any health system. Thank you.
Thank you for that. And Needy, the last word.
Thank you. I'll actually pick up on the question on integration, which is what I wanted to talk about as well. I mean, it is correct that the way that we and many other entities that provide investments for global health, we are set up in a way that's somewhat siloed. And my plea to all of you who are advocates is to advocate for us to get investments that are cross-cutting. We do not have a line item for health system strengthening. We do not have a line item for primary health care. We do have line items for specific diseases, and that's really critical, but it needs to be a both and, not an either or. And the way that we do global health is a little outdated. So we have to change the way that we work to be more focused on what the needs are of partners and what they're telling us.
Excellent. So thank you, everyone. Please give the panel an applause. Thank you very much. The next session is starting, so if you have questions, please ask the panelists in the hallway, because the next session has to come in, set up for logistics. I am presenting on mental health at 3 p.m., so if you want to hear more conversations, please follow me over to that. But thank you.